Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want to answer, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss Greenlight, a laser treatment for the urinary symptoms experienced by men due to enlarged or obstructing prostate, otherwise known as BPH. In previous episodes, we have covered a variety of other BPH treatments, ranging from the historical gold standard, TURP, to minimally invasive surgical therapies such as Rezum, Urolift, and iTind, to more specialized treatments such as HoLEP and robotic simple prostatectomy. So how does Greenlight fit into the spectrum of BPH treatments? How's the procedure performed? What are the risks and benefits? What is the recovery like? And of course, how effective is it? To help us answer these questions, we are joined by a true expert. Dr. Bilal Chughtai is an Associate Professor of Urology at Cornell. He is also an Associate Attending Urologist at NewYork-Presbyterian Hospital. Dr. Chughtai specializes in voiding dysfunction, female urology, and neurourology. He earned his medical degree at the State University of New York at Stony Brook and then completed his residency in General Surgery and Urology at Albany Medical Center, followed by a fellowship in female urology, neurourology, and voiding dysfunction at the Weill Cornell Medical Center and Memorial Sloan Kettering Cancer Center. Dr. Chughtai is also an active researcher. He's served as a primary and co-investigator in numerous studies and has published over 160 peer-reviewed articles, authored chapters and books, and presented at numerous prestigious national meetings. And now, without further ado, I bring you a conversation with Dr. Bilal Chughtai about Greenlight. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about Greenlight, a laser procedure used to treat the urinary symptoms of BPH, or enlargement of the prostate in men. Now, in previous episodes, we really covered the gamut of procedures for BPH, ranging from the old gold standard, known as TURP, or more colloquially as the Roto-Rooter procedure, to more minimally invasive surgical therapies or missed procedures like Rezum and iTind and Urolift, to maybe even more focused specialized procedures for larger prostates like robotic simple prostatectomy and HoLEP. So where does Greenlight fit into the spectrum? What are its unique value propositions? What are its unique risks? Is it better or worse than any of these other procedures? And where does it provide the most benefit to men with prostate problems? Now, fortunately, to help us answer these questions, we are joined by a true expert. Dr. Bilal Chughtai is an Associate Professor of Urology at Cornell, and he also happens to be an expert on Greenlight. Dr. Chughtai, welcome to the program.
Well, thank you for having me.
It's wonderful to have you, and I know a lot of guys are interested in Greenlight as an option for their BPH symptoms. So a lot of guys really interested to hear about it. And Greenlight, because maybe it's a little bit a slightly older technology than some of these missed procedures, doesn't get as much highlights and headlines. And a lot of guys are still very interested in it as a very viable option. So before we dive into all things Greenlight, one thing I'm sure that the guys would like to hear is a little bit more about you. What got you inspired to follow the path of urology and specifically to have this interest in these type of treatments for an enlarged prostate in men?
Absolutely. So I'm a urologist as you said, a urologist at Weill Cornell Medical Center. I specialize in voiding dysfunction. So I did a 2-year fellowship in female pelvic medicine, reconstructive surgery. So my whole focus has been on quality of life. So in females, that really is focused on incontinence. On the male side, it's really BPH and male incontinence. When it comes to the treatments for BPH, I think it's been a very fascinating area, and the fact that it's exquisitely common, a huge impact on the quality of life of these men. And there's been a lot of push and a lot of innovation. And I think with push and innovation, there's also a new sort of like focus on some of our therapies that have been around for a while and how to better apply them. And I think that's where Greenlight sort of plays a very strong role, because on one hand, it is a technology that has been around since around 2012 with the most recent iteration of the 180 watt laser. But at the same time, there has been, like I would call it almost like micro evolutions of changes of like how you approach the pressure bag, the appropriate scopes to use, a variety of techniques of how you create incisions, ensuring the fact that, when you talk about some procedures, they're limited by the anatomy of the prostate. So in other words, 2 lobes versus 3 lobes, high bladder neck, no high bladder neck. But when you talk about Greenlight, it's really able to resolve almost all prostatic anatomies and prostates of almost any size as well. So in some ways, it's a great tool to have in the armamentarium of how to address bladder outlet obstruction.
That's a fantastic way to explain it. Now, I'm just going to dive in and ask a question just based on what you just said. So you mentioned Greenlight as a technique, and you also mentioned a specific type of laser. What is Greenlight? Is Greenlight just a laser that you buy and then you can do something with it, or is Greenlight a whole series of techniques? What is it if you have to describe Greenlight to the lay public out there? What is that?
Yeah, so Greenlight, I think, really is the tool, and it's the specific laser that you're using. So as we know, there's a multitude of lasers. There's holmium lasers, thulium lasers, and there's the Greenlight laser. I think what makes Greenlight sort of unique is that that's a laser that's a 532 nanometer laser, and it's basically a chromophore for hemoglobin. So therefore, it really does target hemoglobin and help reduce bleeding. So it has a very unique laser property because of that. Other lasers like holmium and thulium, they can also address prostatic growth, but they're not as, they may not be as hemostatic as the Greenlight would be.
Got it. So by targeting hemoglobin, which is a component of blood in the bloodstream, and obviously with the blood vessels going through the prostate, it can actually, if you will, neutralize those blood vessels easier and limit the amount of bleeding during the procedure potentially as a potential advantage.
Exactly. So the prostate is a very highly vascular organ. And as we know, if you cut into the prostate, it does bleed quite a bit, obscuring visualization. But when you have a laser that's a chromophore for that hemoglobin or that blood, it can help stop bleeding as you move along. So therefore, it gives you good visualization, ensures that you're staying within the anatomic planes.
So, most guys, if they've ever had BPH, they've been introduced to the concept of the TURP, or the colloquial rotor-rooter, and they've been introduced to it as, if you will, a hot knife or a hot ice cream scoop that scoops away the inner part of the prostate. And we talk about the prostate like a donut, and you're making the donut hole bigger. So if TURP is a scooper, what is Greenlight? Well, how is it different from a TURP in terms of, if you're talking about from surgery perspective, how is it different? What does it do differently?
That's great. So I actually use the same analogy. I use the same hot ice cream scooper or a hot loop for TURP. And when I describe laser, I describe it as more of, you are basically using an instrument that sculpts the inside of the prostate to focally vaporize or convert that tissue into a gas. So what you're doing is this laser is going to literally point at that tissue, and that tissue is going to be, I point the laser at the tissue and I physically remove that tissue, and it gets converted to a gas. So you're creating a space or enlarging that donor hole. So you're sculpting that donor hole to be larger. So that's kind of how I describe it. As for the analogy, I don't really have a good analogy for lasers versus the hot ice cream scooper.
The hot
Because
ice cream is pretty good. Yeah.
yeah, because come to think of it, I don't think there's anything we use that's sort of like a laser to sort of carve out things. I think some of the patients that I have are engineers, and they get it right away, and they're sort of like, oh, so it's kind of like how you'd like carve out a microchip, or how you'd carve out, and I'm like, that's exactly it. But it's the idea of very precisely removing that tissue.
And so, yeah, if you're thinking about the hot ice cream scoop, you're scooping and there's tissue that needs to be removed. And you explained it, very clearly, like your vapor, like kind of the superhero, they have that laser and they shoot something and it's just basically destroyed. It's vaporized, right? So to that extent, it sounds a lot less invasive than TURP, but then how does it comply? Is it considered one of the missed procedures, the minimally invasive surgical therapies, like for instance, a Rezum or a Urolift? Is it in that genre, or is it different?
Yeah, so that's a great question. I feel like what's happening now is that we're having therapies that are coming in almost like two varieties and maybe even a third variety now. So
Mhm.
the two main varieties that we're seeing is that there are procedures that are designed to alter tissue, but you're not actually destroying the tissue, right? In other words, like you're not actively removing that tissue. So that would be Urolift, Rezum, right? So they're taking the tissue, you're either compressing the tissue or putting steam inside the tissue so that tissue shrinks. Then there's truly ablative procedures such as TURP, Greenlight, aquablation, where you are physically making a hole in that donut and you're making it far larger, right?
Mhm.
So I would say that from the level of invasiveness, right, I would say that TURP, Greenlight, aquablation are probably pretty similar. I would say when you talk about mist, you're going to be talking about Urolift, Rezum, and probably iTind now, which is reshaping the inside of the urethra. But in some ways, I feel like iTind almost falls under another category. And we published on this third category called almost like true mist. It's a term coined by one of my colleagues, Dr. Elterman, and that we're talking about the fact that you're literally talking about like the way that cardiac stenting is almost done, right? So in other words, you look in, you go, hey, there's a blockage there, and you can just drop one of these novel stents. So, there's a bunch of stents that have come out from all the way from, I think there's one, butterfly, iTind, the X-Flow expander, ZenFlow, Proverum. So there's a slew of these technologies that have come out that are designed to be temporary and almost reversible. So I think
Mhm.
that's a third category that's sort of starting to pan out as well.
Got it. Got it. Now, when you're talking about who the best candidates for this type of procedure is, one thing you mentioned just a minute ago was that any prostate anatomy can really accommodate this, right? So, like when we spoke to Dr. Ewan about robotic prostatectomy, that was really reserved for really large prostates, right?
Yeah.
Not for everyday prostates. And similarly, when we were talking about iTind, it was really kind of, there were trade-offs there also in terms of kind of like what you're hoping to get versus the risk you're taking. Is there an ideal candidate for Greenlight, or is it really for all comers?
Yeah. I think you're asking the question you're asking, I think in some ways is sort of like, when we talk about any of these technologies, right? There's limitations to every single one. None of them are perfect. And,
Mhm.
and I think you really have to decide sort of like what's the risk benefit ratio. And I think, again, that's where we get into that whole shared decision making. So
Mhm.
when we get into shared decision making, I think there are a couple of things that really pan out for Greenlight. One is, durability, right? I think from a durability standpoint, the fact you're ablating and removing that tissue, Greenlight has a huge benefit there. I think the other area that Greenlight benefits in is anyone on anticoagulation. So in other words, we've all had the experience with TURPs and how you might have this case that looks pretty good as you're finishing up, but all of a sudden it can get pretty red as that patient gets into postoperative period. And once you add on anticoagulation on top of that, it can get really red. And, patients can get catheters again, transfusions. But I think that's where Greenlight really shines. I think the third part about it is that, Greenlight, when it comes to anatomy, like, so in other words, you described how, iTind has some pluses and minuses. Simple prostatectomy obviously is a pretty invasive procedure, but really designed for prostates greater than 80, maybe even 100 grams, right? But I would
Mhm.
say Greenlight, I've done Greenlights as small as 30 grams, and I've done Greenlights as large as 250 grams. So I
Wow.
think in some ways it's able to, really address a variety of prostate sizes. Now, there are limitations to the technology. I do think that as you get into larger prostates, there's probably a higher retreatment rate because it's not going to be as thorough as like a simple prostatectomy. But
Mhm.
at the same time, it's going to be a lot less invasive than a simple prostatectomy. So I
Mhm.
think these are the discussions I typically have with patients about, ejaculatory function, durability, level of invasiveness. Those three factors really play a role in sort of who's a good candidate for Greenlight. I think the other part about it is that I think some of us are attracted to technologies that are sort of brand new and sort of like, hey, this is the latest and greatest. I
Mhm.
think others of us are sort of like, we're data driven. And so I'll see some patients who are like, what have you done the most of? Like, what do you have the most experience with? And I think that's where Greenlight TURP really shines because, obviously all of us have extensive experience. And especially given the fact that this is a technology we've been using since 2012, we've got a good cohort to sort of follow and sort of report on.
Got it. Now you mentioned anticoagulation.
Mhm.
If you have patients who are on blood thinners, do you have them stop it for a period of time for Greenlight, or can they literally just maintain on it throughout the surgery?
Yeah, so I take every advantage that I can. So the
Hmm.
point is that, if I can make my life easy, I mean, if I'm able to stop anticoagulation, I will. And obviously,
Hmm.
I'll do this under the guidance of their cardiologist, neurologist, primary care doctor. But if I'm not able to stop it, I'll forewarn the patient saying that, look, there's always a chance that we might get into so much bleeding, we might have to stop the procedure, right?
Hmm.
But there's a good chance we'll be able to remove all the prostate tissue we need to, and we can keep you on anticoagulation. And I've done plenty of green lights on anticoagulation.
Is there anybody who absolutely cannot or should not get Greenlight therapy for BPH in your mind?
I would say, obviously, patients who are not willing to tolerate any ejaculatory dysfunction, right? So, in other
Mhm.
words, with green light, there's a chance of ejaculatory dysfunction. I think the second cohort would really be those who've had previous radiation.
Mhm.
It seems like once that blood supply changes to the prostate, that healing that occurs after radiation can be quite challenging after a green light.
Mhm. Got it. No, I can imagine that for sure. Now, you had mentioned ejaculatory issues and whatnot. Imagine I'm a patient in your office and I'm considering green light. How would you counsel me on the risks of green light surgery?
Yeah. So when it comes to green light, I would mention with ejaculatory function, like I would, of course, we would have a discussion about the role of iTind, the role of Urolift and Rezum, and how iTind and Urolift have close to a 0% change in ejaculatory dysfunction. Rezum is close to a 6%. Now, with Greenlight, there's a variety of techniques. There's an ejaculatory sparing technique that we've described, and we've had ejaculatory dysfunction rates as low as 10% in this
Wow.
cohort. But for most men, if we're doing a traditional green light, I would say that the rates are about 30% of having some degree of ejaculatory dysfunction, meaning either a complete loss of ejaculate or at least, or some dropping of that volume of ejaculatory volume.
And how does that compare to TURP?
A TURP is around 30 to 50% as well. So, TURP is fairly high. So I would say green light and TURP are probably pretty close, but it really depends on the technique you're using for both.
So, not to get too much in the weeds, but we're going to get into a little bit of the weeds here because I'm sure the guys are interested. Because for the very least, to be able to ask their surgeon, what technique specifically within Greenlight can decrease that risk of ejaculatory dysfunction, meaning decrease the risk of retrograde ejaculation to, as you're saying, near the level of Rezum and Urolift? Because remember, I don't have to remind you, but reminding the audience in previous episodes, right? The whole major value proposition of a Urolift or Rezum is that decreased risk of retrograde ejaculation, which basically means not much semen is coming out, if at all, during sexual activity or during orgasm. Can you comment on that?
Yeah, so I think traditionally we've been taught that it's the bladder neck that really preserves ejaculation. But I think what we've learned from the technology of aquablation is that there's these structures like the ejaculatory muscularis structures and the paracolicular structures that exist right around the ejaculatory duct. And by preserving those structures right around there, you're able to preserve ejaculation probably close to 90% of the time. Now, there is a caveat, which is that, obviously we're looking at a three-dimensional donut in two dimensions, right? So what can happen, especially with larger prostates, is that, you can sometimes leave a little bit too much apical tissue or too much of that tissue around that, or, in that area. And, they may not have the same response or that clinical improvement because you're leaving a little bit of tissue behind. So typically what I try to do in these situations is that my goal is to preserve like the urethral skin or the mucosa that's there, but I
Mhm.
want to try to remove all the bothersome, all the adenoma if I can. So it's almost like lasering around the corner to sort of like make sure that it's not too much tissue, but again, leaving any tissue behind is going to leave a nidus of regrowth as well.
Got it. So it's a fine art by the sound of things. It's definitely not a binary thing. Do most urologists who do green light, do most of them adhere to this type of, or not adhere? Do most of the urologists understand these principles and practice them, or is this kind of more a fine art that might be subspecialized care?
That's a great question. So the answer is, I don't know. I mean, I think, what the problem is when it comes to research on this stuff, right? In other words, when we look at, large cohort data sets, or even, we have a group that we've collected Greenlight data with, it's typically assumed that whatever technique you use, that the end result would be the same. So we don't actually have great data on what techniques are being used.
Mm-hmm. No, that's probably a good point. I mean, it's a little bit of a black box, isn't it, in terms of what's actually happening, right?
Yeah, but that's actually a great question. I think that's a great question that we could probably send out like a quick like a survey to find out what are the techniques that are being used for a variety of these techniques.
For sure. And I think that for those guys listening, it also might be a really important question to ask the surgeon, right? That's going to be doing yours. If of course, retrograde ejaculation is a concern for you. It's not for everybody, but for some it is for sure, right? So yeah, the great point. It's not all green lights are the same, which is very, very important. Now, if I'm going, we talked about retrograde ejaculation. What other risks do you usually go through in terms of like the big ones that people should be aware of after green light?
Yeah, I think classically, obviously, you want to talk about bleeding, right? You want to talk about there's always a 3 to 4% risk of bleeding. Risk of transfusion, although is pretty low. And obviously, if there's bleeding, you may have a prolonged catheter time. There's going to be a risk of urinary tract infection. Most patients 3 to 4%, but some patients obviously with indwelling catheters or high post-void, like other risk factors, may have higher risk of urinary tract infection. Risk of incontinence, I tell patients, is fairly uncommon. In other words, when it comes to stress incontinence, I say it's probably less than 1%. But that's based on our own data. But if you look at the literature, it's probably around 1%. Risk of erectile dysfunction, I typically say it's not going to change after one of these procedures, and that's typically what we've seen.
Can I interrupt you for 1 second there? So erectile dysfunction. Okay, I want to double click on that again real quick. A lot of guys get confused because they hear prostate surgery and it instantly becomes equated with erectile dysfunction, need for medication, whatnot. Now, obviously, as urologists, we understand why, but I'd like you to share that if you could. Why is the risk of erectile dysfunction with green light non-existent really, or minimally, if any existence, versus that traditional concern about quote unquote prostate surgery and erectile dysfunction?
Yeah, so that's an excellent question. I think what ends up happening is that for a lot of patients, there's always a family member or a close friend who's had some type of prostate surgery. And the problem with when you use the term prostate surgery, there's always a bit of a blur between cancer and benign surgery. So when it comes to cancer surgery, there's a risk of erectile dysfunction and incontinence, but we know that when it comes to benign surgery, where you're far away from those nerves that provide erectile function, the risk of erectile dysfunction is fairly low. But in addition to that, there's another caveat, which is that obviously the old monopolar TURPs, like the old TURPs that we used to do, where there was the Bovie pad, the pad that is needed for conduction, and that loop, and you have that electrocautery going from the loop all the way to that Bovie pad, that there was changes in erectile function after those procedures. So the old TURPs probably had some erectile dysfunction. Obviously, when you talk about radical prostatectomy, there's chances of erectile dysfunction. But the third part about it is that for a lot of men with enlarged prostate, erectile dysfunction is a comorbid condition. It already exists. So I think if you're dealing with urgency, frequency, urgent continence, part of your urinary symptoms, it's hard to be sexually active. Then all of a sudden, when these urinary symptoms are improved, you're like, wait, this function isn't so great in the first place. So sometimes it's hard to tease that out, how much of it already pre-exists.
Got
as
it.
well.
No,
so I think it's multifactorial. So I think it's multifactorial of like that whole erectile dysfunction, BPH, prostate surgery. So I think it's a very important thing that I feel like you have to really tease out in the beginning of differentiating, erectile function, ejaculatory function.
Makes a lot of sense. Now, how do you mentioned these risks of green light, which don't sound bad at all? How do they compare to those of the traditional TURP? Is it about equivalent? Would you say it's kind of less, quote unquote, less invasive, less significant side effects? How would you compare the two?
But I would say that the modern TURP, like the modern bipolar TURP, the risk factors are probably pretty similar when it comes to bleeding, infection, and also like there's, the chance of having de novo, like in other words, new onset, urgency, frequency. I would say they're pretty equivalent altogether. And I would say rates of incontinence are pretty similar. I think the biggest advantage of Greenlight really is probably lies within, bleeding and the recovery, because obviously you're healing faster because you're dealing less with bleeding altogether. So your healing time altogether, time out of the hospital, time without a catheter is probably faster with a Greenlight.
Got it. Now, let's say, I'm one of your prospective patients. I'm on medication. It's not really working for me. I'm shopping around for a procedure. I go to Dr. Chughtai and say, you know what, I'm ready for surgery of some sort. Is there any kind of evaluation that I need to undergo under your hands to decide if what's right for me, or kind of decide if for instance, Greenlight's right for me as a procedure?
Yeah. So what I usually do in my practice is that I try to tell patients, like, we're going to follow a couple of, we're going to follow algorithms, and I'm here to help you through this journey. But in this journey, you're the boss, right? So in other words, I'm here to guide you. I'm not going to let you make a bad decision, but I want to make sure that we're really encompassing what your needs are. So I think we've all seen patients who are kind of like, look, I really want to try pills. I want to try supplements. I want to try natural things. So I tell them, like, look, we're not going to do any workup. We're going to keep trying different pills, but at some point you get frustrated with the pills or we don't make progress. Then we'll talk about the role of procedures. When it comes to procedures, I tell most patients there's a variety of procedures out there. I think right now there's, depending on how you count them, could be anywhere between 7 to 9, minimally invasive to surgical procedures for the prostate. And for all patients, I do a cystoscopy, tiny camera inside the penis, to take a look at the prostatic anatomy, answer those questions of what does the bladder neck look like? How far is the sphincter from the ejaculatory duct from blocking tissue? Is it 2 lobes? Is it 3 lobes? How big does it look altogether? Is there prostate growing in the bladder? Then also do a transrectal ultrasound to sort of get the exact prostate size. And the last part about it is some type of non-invasive urodynamics, like at least a uroflow and a PVR. For some patients, we do what's called a urocuff, and external urodynamics to figure out the bladder pressure versus the flow of urine. Or in patients who have a more mixed picture or an unclear picture of blockage, those patients will get formal urodynamics to cinch their diagnosis prior to any procedure. Once we do that workup, usually, there'll be a couple of procedures that they're narrowed down to, probably like 1 or 2, probably 2 or 3, let's say. And those are the ones that we spend our time discussing. Obviously, if someone goes, look, I will not tolerate any ejaculatory dysfunction, that's the patient we're going to lean towards iTind, Urolift. If there's patients who are like, look, I want something with a good, like a long-term good track record, and I also want something that, you've got extensive experience with, that's where we talk about Greenlight.
Got it. Well, that's a good way to break it down for sure in terms of how it falls through. So it sounds like there's a decent amount of evaluation, which is good because it's not all procedures for all comers, right? You really want to make sure you're doing the best thing for them. Now, let's say we did some shared decision making and we agree to move forward. If we plan the surgery, is there any preparation that the patient needs to go to before the surgery?
Absolutely. I mean, prior to the procedure, I usually have them see the primary care doctor just to make sure that there isn't like something else that we're missing. Obviously, when it comes to urology, we're good at that. We're good when it comes to bladder or prostate health, but usually have an evaluation from them if they have any comorbidities. And then usually this is a procedure that we're doing under general anesthesia or spinal anesthesia. So we want to make sure that they'll tolerate that well.
Got it. Do they need to do any kind of prep, like bowel preps or fasting or anything like that before the procedure?
So since it requires anesthesia, they do require to fast the night before. Usually no bowel prep for these procedures.
And how long does the procedure take, generally speaking?
I mean, the old adage was probably a gram a minute, right? So I tell most patients, I would say when you include like the anesthesia time and you include like, getting them out of the operating room, probably about an hour. For very large prostates, maybe an hour and a half.
Got it. Now, a lot of trepidation that a lot of guys have is just really understanding what they're signing up for. Can you, like, on a broad level, explain, like, once they're out, like what you're actually walk them through, like what you're actually be doing?
Yeah. So once they're under anesthesia, what we're going to do is put their legs into stirrups so we can access the prostatic urethra. Following that, we place a telescope, obviously a rigid telescope, a resectoscope within the penis, and then we fire a small laser, very precisely right at the blocking tissue to open up the channel. So what I typically do is map out where the anatomy is, find the ureteral orifices, the tubes that connect the kidney to the bladder, the trigone, which is the neck of the bladder, as well as where the sphincter is. And my goal is to remove as much tissue as possible within that space.
Got
And
it.
then following removal of the tissue, what we'll do is if I did a enucleation or vaporesection, which is basically cutting the tissue out, I'll make sure to remove those pieces. Following that, make sure there's no bleeding, and then place a catheter inside the penis just to help tampen out the area, allow it to heal overnight, and then catheter comes out the following morning.
Do most patients who undergo the procedures do stay the night overnight, or they go home the same day?
Yeah, so I ask patients about how comfortable they are with removing their own catheter. A lot of patients like, I'm not into that. So for those patients, I typically have them stay overnight in the hospital. If there's any patient I'm concerned about bleeding, healing time, any issues that happen operatively, obviously I'll have them stay overnight. But for the most part, if they have no other issues, if they have no concerns about removing the catheter, I'll just have them come to my office the next day, either removing their own catheter, or I'll remove it for them the next day in my office.
Got it. And so, a catheter is a big issue that a lot of guys worry about after these kind of procedures. When you said most of them just stay in for a day, it's not the end of the world. What is that experience when the catheter is removed? Is it painful to remove at all?
Well, the penis is a sensitive organ. And as we know, the catheters we need to place post-operatively are typically a little bit larger than the ones that we place for, operative procedures. So, removing it can be, you can have some discomfort. So, we do our best to add, numbing jelly to the tip of the penis and try to make it as comfortable as possible. But once the catheter is removed, there will be urgency, frequency, burning, and a little bit of blood in the urine for a couple of weeks as they heal.
How does that? So one of the things that came up a lot when we were discussing Rezum was that people can have a not insignificant amount of burning and painful urination after that catheter comes out. How does the Greenlight compare with that, or has there been any comparison made in terms of studies or whatnot?
There has not been a formal head-to-head comparison between the two, but the way I describe it is that what's going to happen is that we are going to create a gap inside your urinary system, right? So basically, I'm going to remove all that skin that's covering the nerves right to that right to the prostate. So since that area is exposed, every time you urinate, you're passing essentially what is salt water on top of a fresh wound. So
Yeah.
you are going to have burning every time you urinate. I assure patients that, look, if you drink adequate amounts of fluid, we'll also give you medicine to help with the pain, things like Pyridium or Urogesic Blue, things to help numb the urinary tract. That typically will subside, will typically keep the pain at a pretty low level. But until that skin grows back, you are going to have a little bit of discomfort every time you urinate.
And you say that people that usually lasts a few weeks?
I usually tell patients about a month.
About a month or so. And is that the only type of discomfort they feel? I mean, people think surgery, they think pain, right? Obviously, there's no cutting involved for this type of surgery. So is other types of pain typical?
Usually not. Usually it's really urgency, frequency, and pain with urination. That's typically what we'll say.
And then
But
what about,
back to
sorry,
what you talked about with, oh, sorry, I was going to say what you were talking about with Rezum. I think there's also, again, with Rezum, a variety of techniques there. We've also described some, low dose Rezum to help reduce that sort of adverse event that occurs after.
Hmm. Got it. So to decrease that burning. What
Yeah.
about leakage of urine? Now, some men talk about, like, even after TURP or whatnot, or HoLEP, the catheter comes out and they start leaking, at least short term, of you not being able to control their urination. Is that as much of a factor with Greenlight? What has been your experience?
Yeah, so with any of these prostatic procedures, what's going to happen is that when you've had this large prostate, blocking the flow of urine, that sphincter sometimes is a little bit on the weak side. So what will happen is when you remove that blocking prostatic tissue, that sphincter's got to work overtime. So a lot of times you may have some leakage in the beginning when that catheter first comes out for a couple of weeks, but as that sphincter gets stronger, typically that leakage goes away. And I would say, persistent stress incontinence is fairly uncommon, like less than 1% when it comes to these transurethral procedures.
So similarly, like the discussion with cancer prostate surgery, this is a very different type of experience with leakage of urine.
Very different, because again, you're not removing the whole prostate. You're not affecting the nerves that go to the sphincter. You're essentially just changing the anatomy within the prostate itself. So it's a limited amount of hopefully effect to those nerves.
Got it. And like we talk about most surgeries, do you restrict your patients in any of their activities or keep them from work after the procedure? And if so, for how long?
Well, it depends on what kind of work that they do, but for most patients, I tell them, you could probably go back to your normal activities, such as walking, going up and down stairs. Just expect to pee frequently, and it might be a little bit unpredictable. And that should last you for about, a month or so, but even after the 2-week mark, you should have a dramatic improvement. Usually refrain from sexual activity for about a month after the procedure as well.
Got it. But they can go return back to work. They can go back to work. They can drive. No real restrictions from that standpoint.
Yeah, I mean, the only issue with driving, I tell them, is like, when you are driving, you are kind of sitting on the prostate. So, if you are going to drive, have frequent breaks, have someone to help you, sort of take turns on driving. Usually try to avoid bike riding, just so that, not actually bike riding stuff, but if you have a seat that can avoid pressure on that perineum, I think it does help them stay more comfortable.
And then how long, or should they refrain from sexual activity after the procedure?
Usually for about a month, because obviously with a orgasm, what's going to happen is that the muscles around the prostate will squeeze and sometimes can cause some bleeding.
Got it. And what would you consider complete recovery time for the procedure?
I tell patients up to 3 months. Depending on underlying bladder dysfunction, it could be up to 3 months before you have a complete, a complete resolution. I tell them at the 3-month mark, if there's any residual symptoms left, whatever it might be, urgency, frequency, that's when we'll typically address it. So I would say that probably you get an 85% recovery at the 6-week mark, probably close to a 95 or 99% recovery at the 3-month mark.
Got it. Now, most guys who come for the Greenlight procedure, or any surgical procedure, they're going to be on medications for the prostate. Whether it be Flomax or Hytrin or whatnot, they're going to be on something. Now, after the procedure, do you just tell them don't take it anymore? Do you taper it off? What's the usual approach with those medications?
Yeah, so typically with the prostate medications, I typically try to stop them at the 6-week mark. So I try to keep them on it in the beginning when they have like more symptoms, more irritation, more swelling. And usually at the 6-week mark, they're usually feeling substantially better. So that's when we typically try to stop the medication. The exception is the 5-alpha reductase inhibitors like finasteride, dutasteride. With very large prostates, sometimes I tell men, look, your prostate grows at a faster rate than your peers. And, you got to this 100-gram prostate because it grows faster. So you have a higher chance of retreatment. And on a medication like finasteride, dutasteride, you can reduce your risk of retreatment going forward.
Got it.
We'll have that discussion.
Got it. But for the alpha blockers, usually about 6 weeks. Now retreatment, right? So this is really kind of where the rubber meets the road. You mentioned at the beginning of our conversation durability, right? In taken in isolation for Greenlight, what is the percentage risk of never having to need another treatment or going back on medication if they're off it? Is there such data available for Greenlight specifically?
Yeah, I don't have great data on the number of men that have to go back on medication, but we know surgical retreatment rates are probably around 5% at 5 years.
At 5 years. And how does that compare to TURP, for instance?
I would say it's probably very, very similar. TURP may have slightly better durability, but again, what's hard about a lot of these data points is that when you talk about TURP, you have the variety of TURPs that are there, monopolar, bipolar, but they're all very similar in how much tissue they remove. With the lasers, the problem also is that a lot of the data will include some of the older lasers, like the 60 watt, 80 watt, 120 watt. And it's hard to use that data with the 180 watt because we know the efficiency of removing tissue is far better with the 180 watt than the other lasers.
Got it. Got it. And in terms of efficacy or durability as compared to the missed procedures, how has there been any evaluation in that respect?
I would say that, when it comes to Rezum, we've seen their 5-year pivotal trial, and they've had um, around when you include meds and surgical reintervention, it works out to around 15%. But if you talk about surgical retreatment rate, it's around 5 to 6%, right, at the 5-year mark. For Urolift, I quote a rate of about 6% a year, but also I find that rate of 6% a year is really probably truer for larger prostates, 70, 80 grams and above to 100. The smaller prostates I find do last a fair amount of time.
Got it. So would you say overall that Greenlight durability is superior to the missed procedures, about equivalent? What is your take on that?
Yeah, so I always tell patients that, just from the standpoint of if we take a 20,000 foot view, if I physically remove the tissue, I know it's gone, right? And I know that the channel we made during the procedure. With Rezum, we're delivering the steam, and that steam could take anywhere between 30 seconds to a minute and a half to remove. But after that, we're really counting on your body to reabsorb that tissue and open up those channels. And I would say most patients will, those areas will reabsorb and look a lot, sort of go away. But at the same time, I think physically removing the tissue is probably going to be more durable.
Got it. Got it. So kind of TURP, Greenlight, probably a bit more durable than the Rezum, iTind, Urolift varieties, more than likely, right?
Likely because we're removing all that, likely because we're directly removing that tissue.
Got it. Got it. Dr. Hold on one quick second. I apologize. All right. Perfect. So we talked about the durability. Now the question is, you had mentioned also that specifically for Greenlight, a lot of variability there in terms of nuance, in terms of techniques, et cetera. Would you say that all or most urologists today perform Greenlight?
I don't know if all urologists do. I would say, there's a fair number of procedures, a fair number of urologists that do perform that procedure. I think, when it comes to TURPs, we've all been trained with that. I think Greenlight obviously is a different technique. So I would say there's likely a urologist nearby that does do Greenlight, but not every urologist does. But I think it's a fairly popular technique.
Are there any, is there a certain number of cases that a urologist should do before you feel comfortable with them, let's say, doing a Greenlight procedure for you as a patient?
Yeah, I think every procedure has a learning curve. I think as physicians, we're always constantly improving and refining our techniques, right? But I would say that, once you've done around 20 to 25 cases, you're probably going to have a fair degree of proficiency. Again, I think it also depends on the specific prostate anatomy as well. So in other words, if this is your, let's say, 10th Greenlight, but now you're going to do a 200-gram prostate on anticoagulation, it may not be the best case to do because that's going to be a more challenging case for even those with extensive experience.
Right.
On the other hand, if your 10th case is a 50-grammer, no anticoagulation, that's going to be a pretty straightforward case that, even those with a more limited sort of experience can probably do a great job on.
And we mentioned asking about specific techniques for ejaculation sparing. Are there any key questions that guys should ask prospective surgeons about before, I guess, agreeing for that surgeon to perform a Greenlight surgery?
Yeah, I think asking questions about what are your personal rate, what if, when it comes to your patients, how many patients have ejaculatory dysfunction afterwards? Is it fairly common? Are there, and then there are a variety of techniques, but you can ask do you use the ejaculatory hood sparing technique? And, those are reasonable things to sort of assess sort of ejaculatory the surgeon's experience with ejaculatory sparing procedures. And not everyone does them, and at the same time it may not be important for every single patient either.
Got it. Dr. Chughtai, thank you so much for your time. This has been really excellent in terms of getting a better perspective on Greenlight. Before we let you go, I'm going to ask you a question completely unrelated to Greenlight surgery, at least I think. This podcast is called Better Man Clinics, and the idea is really trying to reach your best life. What is your secret to your success and to living your best life?
Great question. I would say that for me, I think I try to be present. I try to engage 100% in whatever I'm trying to do. So whether it's in my personal life, whether it's in my professional life, whether it's the green light that I'm doing, I want to put all my distractions away. I want to focus on exactly what I'm working on, be present for it, do the best job I can. And I think it really does help me sort of become better at what I do, and be better even in my personal and my family life, because I want to be available and present and in the exact activity I'm working on.
Such good advice, especially in the world of distraction, of constant distraction that we live in from so many different areas. Dr. Chughtai, thank you so much for your time and for your great insights. And for all of you viewers and listeners out there, thank you for joining us here at Better Man Clinics. And remember our mantra: your best life is a journey and not a destination, and use every day to get just a little bit better. We'll see you all next time.